I'm Dr. Shweta Bansal. I'm a pediatric hemato-oncologist working in Mumbai. Today, we are honored to have Dr. Giselle Sholler with us. She's joining from North Carolina, America, and she's an expert in neuroblastoma. Today, we are going to talk about neuroblastoma. So, a brief introduction about Dr. Sholler. Dr. Sholler is the director of Isabel Center's Rare and Solid Tumor Program at Levine's Children's Hospital. She has been trained in clinical trials management and drug development at prestigious NCI and NIS Center. She founded the Beat Childhood Cancer Consortium in 2010, and it is a consortium of more than 40 universities and hospitals across US, Canada, and Lebanon. She is also a chair of multiple clinical trials, and she has opened 18 phase 1 and phase 2 clinical trials for pediatric cancer, which is commendable. And she's been recently active in working on neuroblastoma, and she has been working on DFMO targeted therapy, which is targeting the cancer stem cells, both in neuroblastoma and brain cancer cells. So she's skilled in oncology, precision medicine, clinical trials, regulatory drug development, and molecular biology. A very warm welcome, Dr. Sholler. Thanks for giving your time. I know you have a huge busy schedule and taking out time for this talk.
Thank you very much.
Dr. Sholler, you are with us?
Yes, thank you so much for that wonderful introduction. I'm thrilled to be here.
Thank you, Dr. Sholler. Thanks for your time.
So, as we know that neuroblastoma is the commonest extracranial solid tumor in childhood, comprising almost 8% of the childhood cancers. But the thing is that still many of the centers are across the world, we don't have the survival rates more than 50%. So it's a difficult tumor to treat. And first coming towards the pre-treatment risk factors, we know that most of the centers, we adopt the pre-treatment risk factors like INRG staging, age, ploidy status, NVIC amplification, and tumor histology. So I would like to know from your experience and at your center, what pre-treatment risk factors you look for and what are the genetic factors you especially look for when you are starting a treatment for a patient?
Yeah, I would say that we use the same criteria that the INRG criteria that you just mentioned in terms of age, ploidy, and amplification. Most recently, in addition, we add ALK as an important risk factor in terms of deciding on therapy upfront as well.
Okay. So you are adding ALK targeted therapy upfront in your patients, or you are keeping it as a later therapy?
We are incorporating it upfront into the initial chemotherapy. If we find an ALK mutation or amplification, we do add an ALK inhibitor currently.
Oh, great to know. So now in the era of newer molecular therapies and the phase of various clinical trials which are coming up, what is the best sequence for treating neuroblastoma? As we know that presently or previously also we were treating neuroblastoma, first we giving chemotherapy, followed by surgery, then giving a bone marrow transplant, followed by radiation, then immunochemotherapy, and then followed by a differentiation therapy. But now some of the clinical trials have come with a humanized antibodies, and they are advocating that bone marrow transplant may not be required in many of these patients. So what is your experience and what is your opinion about that?
So currently, actually, this is very relevant. Just yesterday, we enrolled our first patient on our newest upfront clinical trial where we are incorporating antibody at the beginning based on the results from the St. Jude experience, where they showed that by adding their antibody to the chemotherapy in induction, they were able to increase the response rate, allowing more patients to continue on therapy. They had the CR-VGPR response rate increased from 45% to 70%, and the greater than PR response rate from 80% to 95%, allowing more kids to be able to go on to the bone marrow transplant. And so we are using naxitamab. There are many options of anti-GD2 antibody, but we have started for our upfront patients in the BCC consortium, we'll be using naxitamab in combination with the chemotherapy for the first 5 cycles, followed by surgery after cycle 4 or 5, depending on response and appropriateness for surgery, and then followed with, if patients need additional therapy, our standard is to use irinotecan temodar as well to try and induce better response prior to bone marrow transplant. Ideally, we would like to have patients with minimal disease or a curie score less than 3 moving on to bone marrow transplant. Both in the United States here, it's either BUMEL or tentative transplant. We tend to use BUMEL at our center, but yes, there is definitely question of whether, with the additional therapies that have been incorporated, is transplant necessary? And we know that at Memorial Sloan Kettering, transplant is not used and outcomes are similar. So following the transplant, radiation to the primary tumor, as well as any remaining bone areas. So there are a couple of bone spots. We do radiation to all of those. Then we have a clinical trial where standard for us would be antibody combined with retinoic acid. We use dinutuximab beta, dinutuximab. I know in India and other countries in Europe, it's dinutuximab beta combined with retinoic acid. We do have a study where we are doing that with or without DFMO, so a randomized study to see if adding DFMO earlier might help improve response or decrease the relapse rate. After antibody and retinoic acid, we do standardly use in all of our centers DFMO for 2 years as a maintenance therapy to prevent relapse.
Yeah, so excellent. So regarding that nexapatamab therapy, as you have said, that MSKC is advocating not to go for the transplants and just doing chemoimmunotherapy for these patients. What I understand from your sequence that you are using immunotherapy at 2 points. One is at the induction therapy, and post bone marrow transplant or some intensive chemotherapy, you are consolidating again with the immunotherapy. Is that correct?
Correct. That's correct.
Yeah.
Yes.
Okay. And regarding the transplant, are you doing autologous transplants? Are you advocating haploidentical transplants? What is your idea about them?
Yeah, so we are using the autologous bone marrow transplant with busulfan as a single transplant at our center. But I know that the Europeans and the German groups have done quite a bit on the haploidentical transplant, mostly in relapse setting. But
So another question, which is for the audience actually to know, I know that it's going to be a very difficult question. What do you think, and what is your preference regarding the various different types of anti-GD2 therapies? Now we have murine antibodies, we have humanized antibodies, we have chimeric antibodies, we have immunocytokines, and all those kind of therapies now we are available. And actually, patients want to know about it. So what do you think? Which is the best, and what is the combination is best? Would like to know from
so we haven't had any studies that directly compare dinutuximab beta, dinutuximab versus naxitamab. Those are the 3 standard ones that are being used across, the difference really with the naxitamab and for us, the dinutuximab, is the availability to do it outpatient and then decrease in the time. So the dinutuximab is given, daily, 12 hours a day for the week, for the 5 days, versus the naxitamab on days 1, 3, and 5 for 1 hour, and then 30 minutes on days 2 and 3 and 5. And so it's a much shorter infusion. We are able to do it outpatient without having admission. There's less amount of time in terms of the side effects or the pain for the patient. And that's why primarily we decided to use that one in induction therapy, because we are giving so much chemotherapy at the same time that to do 12 hours of antibody plus chemotherapy is quite a long and quite a bit for the children, whereas we're able to do the naxitamab for either 1 hour or 30 minutes, followed by the chemotherapy. It's more tolerable for both the staff and the patient, and hopefully minimizing the toxicities.
Okay, great. So what are the important toxicities which you're experiencing with naxitamab in your patients?
So the main with all antibodies is pain, and then as well as hypotension or hypertension. Both can occur with the patients, and so we have a regimen where we pre-medicate the patients, and then during the infusion, if there's hypo or hypertension, having medications on hand to manage those. But those are the 3, and then pain as well, the 3 main toxicities.
What about the myelotoxicity? Are you seeing myelotoxicities because of immunotherapy?
Not significantly. Likely we do use naxitamab quite a bit as relapsed setting with either alone or with cyclotopo or irinotecan and Temodar. We've done all 3. With the chemotherapy, there is some myelosuppression, but when we do it without the chemotherapy, there really isn't significant myelosuppression. There's also the hypersensitivity reactions, kind of anaphylaxis that can occur. We have not actually seen that very much, but that is another possible side effect that can be managed in clinic.
So as a single agent for naxitamab, what is the overall response rate, do you think?
I don't have the data with me, but those are the studies from Memorial Sloan Kettering. There was it was about a 30% response rate and that's, I think, that the studies that allowed the drug to become approved in the relapse setting in the United States. So it's now an approved medication as of February 2021, last year.
Okay, great. So regarding DFMO therapy, you are pioneering using the DFMO therapy in various cancers, neuroblastoma and brain tumors. So what is your experience and how you sequence and how you select the patients which should be going for DFMO therapy?
Yes, sure. So we started our first study, a phase 1 study in 2010 to 2012 with DFMO. And in that study, these were, relapsed refractory patients that, had looking for another option for therapy. And so what was interesting on that trial was in the 16 patients, 3 of those patients who had all been told that they were incurable and are all did very well on the DFMO after 2 years. Their scans became PET negative. We saw there was no activity in their tumor any longer. And after 2 years, those 3 patients received no further therapy and are all continue to be in remission today, 8 to 10 years later. And so that was very encouraging and allowed us to really look back at how the DFMO was working, and it really showed that it was the cancer stem cells that were being targeted through the Lin28 pathway. And so in our phase 2 study, we used DFMO as a maintenance therapy. So at the end of upfront treatment or at the end of relapsed refractory treatment, if patients had no disease or no active disease, we gave DFMO for 2 years. And what we were able to show from our upfront patients that the relapse rate improved for patients who are from the end of upfront therapy here at 4 years without DFMO treatment. The relapse rate was about 30% or 70% remaining in remission. And with DFMO, the relapse rate was only 15%. So it decreased the relapse by 50%. And so the event-free survival is 85%. At 4 years, overall survival without DFMO was 80%, with DFMO was 97%. And so that was the outcome that really allowed the FDA to grant us breakthrough therapy designation, and also do a reproducibility study allowing all patients to, at the end of upfront treatment, to receive DFMO without having to do a placebo. And since then, we've worked closely with the FDA since receiving the breakthrough therapy designation to do an even further analysis. So with their help, we were able to, most of those patients who received DFMO had come from the AMBL-032 study, so the antibody study through COG, having received antibody and then went on to DFMO. So we were able to receive the data from COG for the other 1,000 patients who were on that study, but did not go on to DFMO. So contemporaneous cohort of patients that were treated on the same trial but did not get DFMO. And through that analysis with the raw data, we were able to show those same results, Yeah, and we presented this at ASCO this year, and we'll be presenting it further analysis at SIOP in a couple of weeks in Barcelona. Some more sensitivity analysis where we were able to do what's called a propensity score match. So we matched every single one of our patients by 11 factors to find exact patients in the COG database, and by 3 patients matching exactly to our patient showed again those same results. And so we are working with the FDA now to submit for a drug application actually in October of next month. We'll be submitting to see if we can have DFMO approved in the United States for this indication.
Yeah. Great to know this, that this is such a promising therapy. I would like to know, one is that DFMO works on a minimal residual disease, or it can work at a bulk tumor also, like in relapse and refractory when we have a very less options and the patients are like very impatient and they want to do everything for their children. So will this therapy work for their relapse refractory patients also where the tumor is in bulk?
Yeah,
and many other
Yeah, we do have a study for patients with active disease. And kind of looking back at our phase 1 study, again, those 3 patients who went on study, one had a primary tumor in the chest. The other 2 patients had multiple bone metastases. One also had a paraspinal mass. And so those patients who did have active disease were able to respond to it. In that study, we used DFMO, but also we used it in combination with low-dose etoposide for the first 6 cycles, so 14 days off and 7 days on. 14 days on of the low-dose oral etoposide with 7 days off. And so we have that study now in a phase 2 as well. So for patients with relapsed or active disease, that is what we recommend. So not just DFMO alone, but we're kind of mimicking our phase 1 study, knowing that we were able to cure at least 3 patients with that combination. And from the lab work, that does look like it can be effective. Again, those were with bone and then smaller soft tissue areas. None of the patients that had, I would say, lung or liver disease, those patients did not respond on the phase 1. So, so kind of lymph node, soft tissue, and bone marrow. We have seen actually quite a few patients with bone marrow clear with that combination.
Great to notice. So thank you so much, Dr. Sholler. I think it was wonderful talking to you. Maybe we'll like to know more about DFMO, but with the time limitations, we have to stop over here. One request with you is that try to bring these clinical trials to India so that the accessibility to our population can be, I mean, if it is accessible to the population over here in India, it would be great, So many of the patients actually are looking for this kind of a therapy here in India.
Yes, and we have been working with a company that is providing it. I think, and what they have told me is that once the approval goes through, hopefully in the US, we're hoping in the next 6 months or so, that then it will be very much easier to be able to make this accessible in other countries as well. So we're definitely would love to bring this to India. I know that this is an option that would be helpful to be able to reach patients where they are. It's an oral medication. It's a pill that is given twice a day. There's very minimal side effects, and it's stable at all temperatures. So it's something that patients can take home, not have to be in the hospital, which is nice.
Yes. Thank you so much for joining in, and we look forward to your presentation and look forward to these therapies coming to India. Thanks a lot. Thanks.
Okay, thank you. It's wonderful to talk to you.